Great, thank you, and thanks to the organizers for inviting me to give an overview on some of the strategies to improve adolescent care or retention in care throughout. So those are my disclosures. As we're all aware of, the continuum of care cascade for those living with HIV, going from the total number of infected all the way down to viral suppression. And with adolescents, particularly those with perinatally acquired HIV, they have to do an extra step of transitioning to adult care. And as has been described quite a bit at this meeting, and some of these slides are a little bit dated, but just showing you, this is data from South Africa, showing the continuum of care by the time we get from those living with HIV all the way down to those virally suppressed, the numbers are in the realm of about 10%. And similar data from the US, taking those totally living with HIV all the way down through the continuum of care, getting to virally suppressed, it's around about 10%. And as was also shown yesterday, this is some older data, but the concept is still the same from the 2022 data from the UNAIDS that we saw yesterday. At each step of the continuum of care, adolescents do worse than their adult counterparts at each step. But today we're really going to focus on one of those steps, and that's retention in care. So some of what do we mean by retention in care? Really what we mean is having a clinical visit with a healthcare provider that can prescribe medicine. That's basically what we mean by retention in care. And some of my colleagues have said, Brian, why do you care so much about retention in care? What we really want to care about is viral suppression. And I say to them, well, if you're not retained in care, one, you can't tell if they're virally suppressed. Two, they can't collect their medicine. They can't get screened for mental health issues. They can't get screening for STIs. So there's a lot involved with just being retained in care. And so I think it is an important part to get to that viral suppression, which is one of our goals, but not the total goal, but it's also to remain retained in care. And so I just want to go through a few different ways that we measure retention in care. And so this is kind of a graph of 4 different patients and what their sort of continuum looks like over 1 year. So each of those little hash marks is 3 months. Each little check means they attended their clinic visit. Each X mark means they missed a clinical visit. So one of the ways we can look at it is just looking at the number of missed visits. So this, you just count them up, how many visits did they miss versus how many were scheduled. You can look at appointment adherence. So what proportion of the visits that they were scheduled, how many did they actually attend? And you can do that by a percentage. You can look at visit consistency. So this evaluates the time intervals between each visit that each one visit was completed. So in each of those 3-month intervals, how many of those had a visit? What percentage? We can look at gaps in care. So which is the time frame that there was the largest gap in care? And then most commonly, we can sort of make it a binary, either they're retained or not retained. And retained meaning there had at least 2 visits separated by 90 days within a year. And so from our graph, all of those folks would be retained except for patient D, who is not retained. And I think if you just take a sort of ballpark look at that, that kind of makes sense. Like, even though patient B missed a lot of visits, they're still showing up occasionally, so within the year. So that's sort of what we're talking about by retained in care. Oops. But in reality, it fluctuates, right? You can't be just retained or not retained. In reality, there's sort of always going through this motion of they're retained at one point, then they're not retained, they fall out of care, there's a big gap in treatment, sometimes 3 months, 6 months, 9 months, a year, and then they get re-engaged in care and come back. And so this is sort of what we call churn, as they sort of come in and out of care throughout their lifetime living with HIV. And so there are certain, and I sort of put some things into some buckets, but these all can overlap with each other. and some of them, can fit into more than one bucket. But there's really several different facilitators that can help retention and care. One is there's some structural changes that can be done. There's psychosocial support. There's re-engagement in care, finding those that are out of care and getting them and bringing them back in. And then there's the potential for some M-Health support to do and cross-cut some of those other facilitators. So this just lists a number of examples, some of the structural things like youth-friendly services, having flexible hours, having community mobilization or mobile clinics, having case management assigned to different cases, using motivational interviewing during visits. And then for psychosocial support, there's always the importance of peer support, of disclosure support, and access to mental health services. Re-engagement, there's been outreach, mobile vans and things, and peer facilitators bringing people back into care. And then M-Health, there's different ways. There's sort of one-way messaging, sort of appointment reminders and adherence reminders, or two-way messaging where you can start a conversation and go back and forth. But really, none of that, or particularly none of the psychosocial things, can start without disclosure. So I like to think of getting disclosure, and by disclosure in this instance, I mean having the adolescent aware of their own HIV status. Without that knowledge, they can't access any of those psychosocial services because you can't say the word HIV and you can't talk about it. So to get the ball rolling, you really need disclosure, and then that can open up access to social support, peer support, mental health services, that feeling of belonging, feeling like they're equal to others, and then that really helps retention and care. But there's a lot of barriers. I just listed some here, but we could probably fill 3 or 4 more slides with some of the barriers to adolescent retention and care. But some of the common ones that we know about, poverty, food insecurity, transportation, all those sort of financial issues, the clinical issues. A lot of times adolescents complain about being yelled at by the staff and having unfriendly staff, not connecting to the staff. Long wait times is often a complaint when adolescents transition from peds to adult care. They complain about wait times. Then there's, of course, interference with school and work, which I often call the student's paradox, where either they can attend clinic or they can attend school, but they can't at the same time. So they have to miss out on one or the other. And then, of course, there's all the psychosocial barriers. There's loss of family members, there's changing caregivers, there's stigma, either perceived stigma or enacted stigma. There's disclosure, which we talked about, not just disclosure to them, but also disclosure of their status to others. And this often among adolescents, creates a dilemma about talking to their friends and feeling isolated and not feeling close to their friends because they have this big secret that they can't share. We often call that the disclosure dilemma. And then, of course, unaddressed mental health needs. In a lot of places, it's not screened for. Even if it is screened for, there's often not access to services for mental health in a lot of areas. And I like to think of this as sort of kind of a push and pull, or going up and down the hill. There's certain barriers that help, there's certain things that hinder, and this can all be in motion and going back and forth over time. But really, you need to get over these big humps of disclosure, social support, and mental health in order to be retained in care adequately. And there's a bunch of, I mentioned a bunch of different types of interventions addressing retention and care, or that have been tried to improve retention and care. One of the big ones, adolescent-friendly services. There's community-based adherence support, economic empowerment or nutritional support or financial support. There's been several types of M-Health interventions, differentiated care towards high-risk patients, and then decentralized care. And again, some of these can overlap. I'm just going to highlight a few of these interventions and sort of what's been going on in the larger buckets. So adolescent-friendly services, there's been a number of studies that have shown some positive results, but there's also been several that have shown no impact, right? So does it work or doesn't it work? What can we do? Well, it depends on what you mean by adolescent-friendly services. There's this huge thing that can be adolescent services. Is it just education and career support, or is it just training the staff to be friendly and to not yell at the kids, or is it to have nice access to Wi-Fi and comfortable couches and pretty posters on the wall? That's great, but that may not just keep them retained in care. So it's all of these different things can be considered adolescent-friendly services, and it depends what you have. So in one of the studies, this is one that I was involved in, the adolescent-friendly services involved a lot of these things, not just one or two, whereas some of the ones that were seen as not effective or didn't show any outcome only focus on maybe one or two. And the common ones are sort of the bottom two, where they make the clinic look friendly and be open and welcoming to adolescents, and they train the healthcare staff, but it doesn't address a lot of the other potential for adolescent services that are out there. And so at the study, before this clinic, we really designed it based on identifying those barriers, getting input from adolescents. What do you want? What's going to help you with some adolescent-centered design? And so we were really able to look at the three main barriers that we were seeing at this one particular clinic, which was the student's paradox, balancing between attending school and attending clinic at the same time, this disclosure dilemma where they didn't want to talk to their friends about living with HIV, and then having this conflict with the clinical staff and fighting and getting shouted at for being late to their appointments or not taking their medicine. So we designed an adolescent-friendly services clinic to address those three main issues, because that was the three main issues. So to just address the student's paradox, we had an after school hours clinic. So that got rid of that. To address the disclosure dilemma, we built in peer support, where all the kids there were living with HIV, and so they can be open and honest and talk about it amongst their peers within the clinic, and so not be afraid to discuss it in the open. And then training the clinical staff to not yell at the kids for being late and not yell at them for missing their appointments, and realizing and working with the adolescents and working with their lives to move things forward. And so those were sort of the things that we did to help retention and care. There have been some other positive things, outcomes from some community-based adherence support. This is often using, peer counselors or meeting people in their homes or in a community environment to help bring them into care. And some of those in Africa and South Africa and Zimbabwe have shown some positive results in retention and care. As have some economic and financial incentives, somewhat different from a lot of the prep work and prevention measures. That's also had a lot of mixed results, but some of this has shown to be a little bit more positive or leaning positive towards retention and care. M-Health, there's increasing and growing evidence of M-Health interventions that are out there. Some have shown no effect, and others have shown some positive effect. This is one of the studies that we've just not yet published, but that I've been involved in. We designed a M-Health with adolescent input. We designed an M-Health intervention that was delivered over 10 different modules based on educational topics that they wanted, where they could text each other, and it was facilitated by a facilitator to help guide these discussions. We actually did a randomized controlled trial with 40 adolescents attending these M-Health INCHA sessions and 40 in standard of care. And those in the intervention group, retention and care was 98% at 6 months after the intervention, compared to the control group, which was 88%, and that was statistically significant. So some hint towards some M-Health interventions may also be working. But again, we targeted a lot of those adolescent-friendly services within an M-Health delivery system. So it wasn't just text messaging, hey, keep your appointments tomorrow, don't forget. It was a lot of these other things as well to build up a lot of these services. So M-Health does have quite a bit of potential. There's the push notifications that we all think of as appointment reminders, positive messaging, hey, take your medicine, take your medicine to stay healthy, all that sort of stuff. But there's also this two-way messaging where you can contact and discuss with your healthcare provider or discuss with other peers. But so far, there's been limited efficacy in adolescents for a lot of these interventions. And in adults, there's been quite mixed results. Again, some showing some positive, some negative. And there's a lot of potential challenges with M-Health interventions, particularly in resource-limited settings where there's issues with poor network, power outages, in South Africa dealing with load shedding and not having access to Wi-Fi. A lot of diluted messages. If people are getting a lot of text messages, then they often ignore them, and some of the more important ones get pushed to the bottom, kind of like our own emails, especially when we're in a meeting. It does require phone access, shared phones. There's been issues that we had with adolescents not having their phone, but using their parents' phone or their siblings' phone, and then they want the phone at the same time that the intervention's supposed to happen. So there's a lot of these issues. And of course, data costs are quite expensive in some settings. There's issues with confidentiality and privacy. What if people see some of these text messages on your phone? Obviously, in ours, you make sure that it's encrypted and people can't read your messages. We had one of the issues when we were designing this app was what delivery system could we use it, and they were really concerned about having it, a new and brand new app on their phone that their friends didn't know what it was. So there was that stigma of a new app. So somebody would say, hey, what's that thing? And then, they didn't want to say what it was. So that's why we used WhatsApp, because everybody uses WhatsApp. So, and then there's obviously potential for disinformation and bullying, and that's why we had a facilitator in ours, in our intervention, because some of those chats can get derailed and go in crazy directions. So monitoring and control of the dialogue that's going on is quite important. So. And then there's differentiated services, and there's, again, a lot can fall into this bucket. Adolescent-friendly services can also sort of be considered differentiated services, but how can we get those target services to those that need it the most? Those that are doing great, that are virally suppressed, that are retaining care, they may not need extra services, and we can tailor it to those that really do. So putting more attention into those that need it. Currently, there's a little bit limited data on specifically differentiated service interventions for adolescents, but there are some examples of support clubs, adherence groups, multi-month dispensing, mobile clinics, things like that, but data on retention and care is pretty spotty. So the basically important concepts to retention and care, that psychosocial support is very important. Be that peer support, be that caregiver support, or healthcare provider support, community support. Financial support seems to help, right? Giving people money, access to grants, helping with transportation, nutritional support, all that is helpful. Community-based or home access services seem to be likely helpful. Early disclosure is important. As I said, you got to get the ball rolling down the hill. Minimizing school disruptions and after-hours clinics, and mental health screening and treatment. So none of this is like, wow, this is amazing, I can't believe this. It's pretty obvious stuff. The more services you give to adolescents, probably the better they're gonna do. If some of them leave them to their own device, they're probably not gonna do so well. So thinking about which ones work and which don't, and what can we focus on, I think that's a little bit different based on the setting, but that's where sort of research and some of answering some of these questions can go in the future. So how do we scale efforts that we know work or think work? How do we create interest and buy-in at the clinic level? It's one thing to do a research study where it's all paid for and nice and structured, but then when you move it out into the clinic, who's going to take over this? Who's going to pay for it? A lot of those questions aren't often answered. And then how do we fund the interventions? Of course, when the research is done, how do we take it and deliver it and have people buy in and want to continue this? So there's a lot of gaps that remain and questions that remain. A lot of these interventions that have been done are sort of investigator-driven and not really led by adolescents, and having youth ambassadors, youth champions, and youth-developed programs. I think that's a major gap in where we are right now. Particularly other ones developed specifically for key populations. There's a huge gap. We don't have many developed for pregnant adolescents, youth who inject drugs, transgender youth, sex workers, youth who are incarcerated. All of these are major key populations that struggle with retention and care, and there's really a limited amount of interventions targeted for them. And then long-acting injectable medication. Nadia, sorry, I do believe that it's helpful. Maybe not for everybody, but I think in the long run, and particularly if we can get that past the 2-month hurdle, get it to 3 months, get it to 6 months, then we are talking about game-changing for retention and care. So my last slide, I really sort of want to plug, and sort of in Nadia's realm, using implementation science to answer a lot of these questions. And so there's a lot of different implementation frameworks. RE-AIM I kind of like because it's easy and it's easy to remember because it's an acronym. So just thinking about this when designing studies or designing programs, or you have an intervention or program that you like and you want to build it out, think about kind of hitting on these things when you're looking at it. You know, the reach. Is it representative across age groups, across genders, across, you know, rural versus urban areas? Is it effective? You know, do we have a randomized controlled trial to determine this is effective? If so, what are the important pieces? Is there a comparison group? Does this work in a real world setting outside of a clinical trial setting? You know, and is it going to be adopted when you withdraw it from the research world? Do you have champions that are going to carry it forward? You know, implementing it, you know, how are you going to maintain fidelity? You develop this wonderful intervention, you know, in your clinic. How is another clinic, how are you going to be sure that they do it exactly the same, or hitting on the important pieces that work the same to carry the intervention forward? You know, how much does it cost in terms of time and personnel and training? All of those are important. And then, of course, maintenance. Once again, once you leave, is it going to be able to be sustained? What are long-term outcomes? A lot of times we look at 6 months or 1 year, but you know, these are adolescents that are adolescents for a number of years. So is it going to last beyond that? So I just want to thank all of my collaborators and colleagues who've helped along a lot of these researchers and helped develop some of these slides in this talk over the years. And yeah, thanks all.